Hi, this is Terry Kuti. I am the founder and director of Deep Sea Foundation. I'm also a two-time breast cancer survivor who has had multiple breast surgeries and also breast reconstruction. I have a fortunate opportunity today. It presented itself and I was asked to invite two amazing surgeons that were part of my shared decision-making team from my second breast cancer diagnosis and through my reconstructive surgery. I'd like to introduce them today. I want to introduce Dr. Michele Ley, who was my breast surgeon. She's a fellowship-trained breast surgical oncologist, and she's in Tucson, Arizona. Welcome, Dr. Ley.
Thank you for having me, Terry.
So good to see you. I also want to introduce Dr. Minas Chrysopoulo, who is a board-certified plastic surgeon, breast reconstruction, and microsurgeon. He is also the founder of the Breast Advocate app, which is a free decision-making tool for breast cancer patients. Dr. C is in San Antonio. Welcome, Dr. C.
Hi, Terry. Hi, Michelle.
Hi, Mina.
It's so good. It just is so good for me to see both of you together here. It's a special moment for me, really. So, you know, the process from diagnosis to reconstruction really, in my mind, is a continuum. And I was very fortunate to have an amazing shared decision-making experience from both of you. I don't think that happens for all patients. So the focus of this video today is for really both of you. I want to talk to both of you about how you go about really feeling out a patient and finding out how much they really want to be a part of the shared decision-making process and all that comes with that. The caregiver, the coordinated care team. You know, I remember, Dr. Ley, before I left to go to San Antonio for my reconstruction, asking your nurse, if I come back with drains from my reconstruction, would you guys take them out for me? There's a lot more coordinated care than that, but to me that was important to know that. It was peace of mind. I'm going to let you guys talk about this. It's just an amazing process for patients. I want them to hear what it involves.
Thanks, Terry. I'll start with when patients are diagnosed. You know, one of the challenges we face is that patients are very stressed naturally. And you're meeting them kind of on the worst day of their life. So that can be difficult to assess their values and what's important to them. And then we don't have a lot of time with people. You're not sitting there having coffee. You're trying to educate them about their diagnosis. So I always start with education, teaching people what are all the parts of the therapy. And when we get down to talking about what the surgical options are, it's not really standard, actually, that reconstruction is brought up when mastectomy is given as an option. But I really try, and I think a lot of fellowship-trained breast surgeons, it's part of our presentation to patients, but not all. And because part of our training is to work with plastic surgeons, to bring that up early on to patients so they know they can have some kind of reconstruction. But it does take thinking about the patient's whole course of their disease right on the spot there in order to understand what kind of reconstruction they might need. You know, if you have someone that you know for sure needs radiation, then maybe implant reconstruction isn't right for them, and they need to know that implant reconstruction has a higher risk of complications and that maybe a flap reconstruction is better for them. So you have to put all that information together quickly and think about not just what surgery you're going to do next week, but what the next 6 months of their therapy looks like so that you can help them plan for that. But that's not always easy to do. And then patients aren't always receptive to talking that far ahead either. So sometimes they're so stressed out at the first visit that they can't really think. And so then I usually have them meet with a plastic surgeon if we're even considering it, so that they can start having that discussion right away and gathering information. So we really I try to emphasize the gathering of information, give them information to read, like Breast 360. We have some books we use, things like that.
Mm-hmm. Dr. C, thoughts?
Yeah, I think I completely agree with what Michele just said. I think it's as a plastic surgeon, it's very nice to hear that what we're going to be facing and what we're going to be dealing with is being taken into account. So you'd think that was a given, but unfortunately, this collaborative approach isn't everyone's experience. It's not every patient's experience, and it's a two-way street. So breast cancer care is always going to be the outcome is always going to be better if it's viewed as a multidisciplinary approach, right? And so it's always going to be life before breast, and so the breast surgeon's needs to perform their best and to give the patient what they need from an oncologic standpoint is always going to take priority. But there are decisions that plastic surgeons can be a part of in terms of incision placement, in terms of staging, in terms of impact on radiation, by radiation. So all these are conversations that are best had in a multidisciplinary setting. Unfortunately, some patients, that's not the experience. And so I think it's important for patients to understand that absolutely it's extremely emotional, but the patient has time. There's time to get a general idea of options, and even ladies who are considering reconstruction, absolutely, some of them find it overwhelming to decide on a method of reconstruction and to have immediate reconstruction. And there's a lot to be said for many women to just delay that decision and get through the cancer treatment first. But to Michele's point, knowing about the options ahead of time can be a massive help. It can provide hope. It can provide relief. And quite frankly, sometimes even going flat is a multidisciplinary decision, right? Because not all surgeons are on board with that philosophy, right? So it doesn't matter. We do a lot of deep flaps, a lot of perforator flaps at PRMA, and people find what I'm about to say a little strange sometimes. But I don't care what the patient chooses. I honestly don't. The final procedure they have is actually irrelevant. What's important is the choice and that the patient decides the level of autonomy that they need.
Right.
Some patients, they look at you and they say, doc, I'm so overwhelmed. I just need for you to tell me what you would do if this was your wife. Okay, but they're telling you that that's what they want. They're deciding. That in and of itself is actually shared decision-making.
Right.
Even though, the decision may be made in the end in a paternalistic way, the patient is telling you that's what they need. So, I think it does take time for individual surgeons to work out how shared decision-making is going to be incorporated into their practice. It's definitely standard of care, but it's not standard practice. But it also doesn't have to take an immense amount of time. I mean, I have shared decision-making visits with every patient, and it can be done in as little as 15 minutes, or it can take as long as we need for it to take. Decision aids can help. I obviously use the Breast Advocate app a lot. Everyone downloads it before they come. That saves us a ton of time in terms of the consult. but whatever you use, I think it's important for physicians to really analyze how their clinical pathway works within their practice and see how best to fit it into their style. I don't think there's a right way or a wrong way.
Right.
No, I have to say, listening to you both, and I'm going back. I'm going back to the moment that I sat in your office, Dr. Ley, and then the moment that I sat in your office, Dr. C. So from an educator standpoint, from a patient advocate standpoint, what I'm taking from what you guys are saying, education, tools, material first, time, and then helping the patient through that decision process based on your skill level. So to me, that was the continuum for me. I remember the day you handed me all the brochures. And then I remember the day you used the word gold standard. Deep flap is the gold standard. I think you should look into that too, Terry. And then I go to Dr. C after I'd already decided I was going to have deep flap. He started talking about all the aesthetic options, not options, but the aesthetic outcomes. You know, where are we going to place this scar? You've had radiation in the past. You had a skin sparing, nipple sparing mastectomy. It is so much to process, but to me, it's the education. It's giving it to the patient, giving them the time to process it, and just standing with them through that entire continuum.
I really like that we're all talking about the time, because I agree that's one of the mistakes patients make, is that they feel like they have cancer and they have to take care of this next week, and so they rush to surgery. They go to the first person they're referred to. They don't ask a lot of questions. They don't think they can ask questions. And how would you know what the options are when you've never had to have breast surgery before? There's no way that people know that. People don't know that you can have a reduction with your lumpectomy, and that might make your radiation better, or that you can do an oncoplastic resection or incision placement for your mastectomy, or incision placement for a lumpectomy and you end up needing a mastectomy. That's one that we see sometimes. So taking that time, slowing it down, taking the time. And for a lot of cancers, we can do temporizing measures. We're doing it a lot now because of the pandemic, but putting people on aromatase inhibitor or tamoxifen or on chemotherapy if they need it, doing those kind of things gives patients time to really think about their options. And they can meet with me multiple times throughout their chemotherapy. They can meet with the plastic surgeon multiple times throughout their chemotherapy, so that they've really felt like they've had an education and can make a good choice. So I think that's really an important element, is that slowing the pace down. I think too, oh, go ahead.
Yeah, I was going to say I think that's spot on. And I think, though, some patients feel that the healthcare team actually may be adding a little bit to the sense of panic. And I can understand why, it's, get the patient through and get the cancer treated and all the rest of it. But if we can collectively, I think, do a better job of what you're saying, from a reconstruction standpoint, it's really important, because, a lot of patients don't have access to what they would choose if they had all the options up front. They don't have access to that locally. So temporizing measures actually, come into play with us too. Not every patient has the luxury to travel. Not every patient needs to travel. Not every patient wants to travel. But for certain procedures, for example, a tissue expander as a temporary measure is perfect, because then the patient gets to finish their treatment locally. And, if you use us as an example, people traveling to us, the breast cancer issue is the treatment is taken care of, but the patient still benefits from a nipple sparing or a skin sparing mastectomy and preserving the soft tissue envelope with a temporizing measure, a tissue expander. And then so it isn't all kind of rushed, and
Right.
nothing is done to compromise the most important thing, and that is the cancer care.
Mhm. That's good too to talk about the delayed reconstruction, because it's when I started my practice, there wasn't a lot of immediate reconstruction in Tucson, and we've switched to doing mostly immediate reconstruction. But it's also okay to talk to patients about doing delayed reconstruction. I did that the other day for a very young woman who we know she'll need radiation, and a free flap's probably her best option. But if we don't have that option in Tucson available, then delayed reconstruction is better for her. And so keeping kind of all those pieces and parts in your mind as you're talking to patients so that you can kind of map it out ahead of time for them.
Mm-hmm.
The other thing I was going to say, Terry, you'd mentioned about the caregivers. I think that some patients really need their caregivers to make decisions, or to help them make decisions, not make decisions for them, but to help them make the decisions. And so that's something that is another thing with the time. Go home, talk it over with your family, or your friends, or whoever your support is. And then also to be sure that your family or friends can help you after surgery, because some of these surgeries require extensive healing time and require help. You can't heal from a breast reconstruction by yourself for the most part. And you'll have more complications if you go back to work too soon and things like that. And getting the family on board to help reinforce those things at home. Don't let your family member do the laundry for 6 weeks, that kind of thing, like no heavy lifting and all those things. That really enables us to have a lot of more success, a higher level of success, because you get the family engaged in the decision making and the buy-in to whatever path they choose.
Mm-hmm.
Yeah, I do think it's an important part. I consider them part of the coordinated care team outside of the, healthcare team. That's so important. You both have touched on some very amazing topics today. And I wish we could talk longer. We're going to have to wrap it up, but because time constraint. But I want everyone to know, to take away from this, that I think find a support community, find doctors that are going to listen to you. That's the first thing I remember about both of my consults with you. You listened to me first. You listened. And so if a patient comes out of a consult and one of the first things they feel is, I don't feel like I was listened to, it's okay to get a second opinion. It's okay to find someone else. It's all part of the shared decision-making conversation. And the tools that you talked about today, Dr. Ley, you talked about the Breast 360 website. It's an excellent resource. The Breast Advocate app, I didn't know about it when I met Dr. Ley, but I'm on board with it now and share it with so many people, breastadvocateapp.com, because of its decision-making power for the patient. I want to thank you both today. This has been an incredible opportunity for me to have you. Unfortunately, not in the same room, but sort of.
Someday.
Hope so.
Yeah.
Yeah. Thank you both very, very much, though, for taking the time today to talk about the important topic of shared decision-making, from diagnosis all the way through reconstruction, if that's what patients choose.
Thank you. Thank you both.
Thank you.
All right. We are very honored to have both of these surgeons here today. So please, follow us on Facebook, on YouTube, Deep Sea Foundation, and thank you again for joining us for this important topic today.